Hello everybody, this is Dr. Tilak from the Department of General Medicine, Medicity. Today I'll be discussing examination of cranial nerves. Last time I have discussed examination of the sensory system and motor system. So today it will be continuation of the examination of the nervous system, and it will be cranial nerve examination. So it is also just like other examination, quite important in the assessment of patients who have got some neurological disorder. So before we proceed with the examination of cranial nerves, we should be familiar with the basic elementary anatomy of different cranial nerves, what they are and what their functions are. So you should know how many cranial nerves are there, what their names are, and what their basic functions are. Then only you will be able to examine them properly and find out which nerve is affected and what the likely syndrome is. So there are basically 12 cranial nerves starting from 1 to 12, and all these nerves except 2 or 3 do not have, all of them have got a specific nucleus somewhere in the central nervous system, mostly in the brainstem, except cranial nerve 1 and 2. Others have got a nucleus in the brainstem. So that helps, this knowledge helps in the localization of any lesion which is affecting one or other cranial nerves. So if you look at the cranial nerves in human beings, as I mentioned that, well, you should know the names of all the nerves, whether it is olfactory, optic, oculomotor, trochlear, trigeminal, abducent, facial, auditory, glossopharyngeal, vagus, spinal accessory, and hypoglossal. So you should know the names, and also you should know which number it is. Okay, so it will help not only in exam but also in the assessment of the patient. And then you should also know what are the functions of these individual cranial nerves. That will help in the assessment of which part of the brainstem or which cranial nerve is affected by a disease process. So if you look at the different cranial nerves, these nerves have got different types of functions. Some of the nerves, cranial nerves have got sensory function, some have got motor functions, some have got some autonomic or parasympathetic system function. So all the cranial nerves do not have all these functions. Some are purely sensory, some are purely motor, some have got mixed function. So if you look at cranial nerve first, that is olfactory nerve, it has got basically sensory function, but it does not have any motor function or any autonomic or parasympathetic system function. The number 2 nerve, that is optic nerve, has got again only sensory function, no other function is there. Oculomotor has got motor function as well as it has got parasympathetic system function, but it does not have any sensory function. Trochlear is mostly or only purely motor cranial nerves. It does not have any sensory or any other function. But trigeminal nerve of 5th cranial nerve has got sensory function as well as motor functions, but no autonomic function. While 6th nerve or abducent nerve has got only motor function and no other function. If you look at the cranial nerve 7, it has got sensory function, motor function as well as parasympathetic function. While the vestibular cochlear nerve has got only sensory function, no other, no motor, no autonomic function. While glossopharyngeal nerve and vagus nerve both have got sensory, motor and autonomic function. Accessory and hypoglossal nerve, that is 11 and 12 nerve, they have got only motor function and no sensory or autonomic function. So in this way, it is clear that some nerves have got only motor function, some have got only pure sensory function, while others have got mixed function. So we can divide the cranial nerves in different ways. Like purely sensory cranial nerves are the number 1, number 2 and number 8 cranial nerves. The purely motor cranial nerves are number 4, number 6, 11 and 12th cranial nerves. While the cranial nerves which have got mixed functions, they are number 5th, 7th, 9th, 10th and this number 3rd, that is oculomotor nerve. So if you look at the examination, you should know the function, what are the functions of the individual cranial nerves. The number one cranial nerve or olfactory nerve, it has got purely sensory function, which is basically olfaction. So basically sensation will start from the olfactory epithelium in the nose, then it will go into the olfactory bulb just below the frontal lobe of the brain. Then it will proceed, of the projections will be to various parts of the brain, like the frontal lobe or temporal lobe or even basal ganglia, different parts of the brain. So the basic function of the first cranial nerve is the olfaction of sensation of smell. So basically, why we test the first nerve? Just to see whether the patient has got normal olfactory function or there is any impairment of smell or not, and if it is there, then whether it is unilateral or bilateral. Then it may be due to some local lesion in the nose, or it may be because of some central nervous lesion. So that will help in the localization of the lesion based on associated findings in the clinical profile of the patient. So when you basically examine the first cranial nerves, you should use those items which the patient is likely to be familiar. It may be simple items from the daily use, it may be some coffee, or it may be some soap or lemon or similar things. Whatever the patient is likely to be familiar, you should use. Don't use something which the patient is totally unfamiliar, the patient may not be able to recognize. So use those items which are known to the patient. So in that case, what happens? You have to test only one nostril at a time. So you close the other nostril, and then you bring something which the patient is likely to be familiar. You can tell the patient in advance that there are 3-4 items, and I'll bring near the nostril. You smell it and taste what it actually. Just see whether you can feel the smell or not. So one nostril at a time, bring something familiar, and then see whether the patient can feel the smell or not. So once you see whether the patient is able to feel the smell or not, then you have to interpret the results. But the results will be different in different individuals. There is a difference between the males and females. Females have got higher acuity as far as olfaction is concerned compared to males. So depending on that, you have to see. So first you have to see whether the patient can recognize there is a smell or not. Secondly, whether the patient can name what odor it is or not, and whether it is bilateral, symmetrical or not. So you have to take into consideration all these points. First, ability to smell something, then ability to name it, and whether it is same on both the sides or not. Depending on that, you have to find out whether there is anything wrong or not. So the olfaction may be affected by various disease. It may be a local disease in the nose, or it may be disease in the intracranial compartment. Like local disease may be because of some inflammatory condition or infection around the nose. It may be chronic rhinitis or sinusitis, or sometimes because of heavy smoking, or sometimes because of head injury. There may be injury to the olfactory bulb. Again, the loss may be there. So presently it is the corona infection also that may also cause loss of olfaction. So it may be because of inflammatory conditions or inflammation, some smoking, injury, or there may be some tumor in the anterior cranial fossa which is affecting or compressing the olfactory bulb. Sometimes it may be because of chronic conditions like degenerative condition, Parkinson's disease may cause, or sometimes chronic condition of the meninges can also affect the olfaction. So this etiology will find out based on other associated findings. The other examination of the cranial nerve is the examination of the second cranial nerve or the optic nerve. As you know, it is a purely sensory nerve which carries the sensation of vision and other parts of vision, with the field of vision or color vision. You should be familiar with the pathway that will help in the localization of the lesion in case there is any involvement of the visual perception. So as you know, the optic nerve will be there, then it will reach the chiasma, then the nasal fibers will cross to the other side, the temporal fibers will remain on the same side, then it will reach the lateral geniculate body near the thalamus, then it will go to the occipital cortex. This you should know, because half of the fibers will cross and half will not cross. It will result in various types of visual field defects if the lesion is situated at one or the site in the optic pathway. So basically it is a purely sensory cranial nerve. So whatever the impulses from the retina, they reach the occipital cortex through the optic chiasma, optic tract, and the lateral geniculate body. And also it participates in the pupillary light reflex. So basically why we do it, basically we want to see whether the vision is normal or not, and if the vision is normal, we have to see whether the field of vision is normal or not, or the color vision is normal or not. All these things we have to see just to see whether the second cranial nerve is normal or not. So basically you can check the visual acuity either for distant vision or for near vision. So different charts are available. For distant vision, Snellen chart is there, and for near vision the Jaeger's type chart is available. So you have to check the visual acuity for both distant and near vision. And then you have to see whether the visual field is normal or not. There are different methods for that. One is the bedside, what is called confrontation method, or otherwise you can do the examination for the visual field defect in the ophthalmology department with a special apparatus. So when it comes to bedside examination of visual field, we follow the confrontation test. In that what happens, the patient and the examiner will sit in front of each other. The distance between the two will be around 1 meter, and they should sit at the same level so that the eye of the examiner and the patient are at the same level. So while you check one eye of the patient, for example, if you want to check the left eye of the patient, you should use your right eye so that they are on the same side. Then you have to bring something, it may be a finger, maybe some pen from outside, either from upper part or lower part, and then see. When you are able to see, the patient should be able to see. So just to compare your field of vision with the patient's field of vision. So you bring the finger from outside, then bring the finger from medial part, upper part and lower part, and when you are able to see, patient should also see, otherwise it may be suggestive of some visual field defect. So there are various lesions, various types of etiology which can cause either loss of vision or some field defect. There may be total loss of vision whenever there is severe injury either to the optic nerve or to the eyeball. Okay, sometimes it is not the entire vision of one eye, but only part of the visual field is affected, and there are different types of field defects which may be there. For example, it may be homonymous hemianopia, or it may be bitemporal hemianopia, it may be quadrant anopia also, depending upon where the site of lesion is. So you have to check the field of vision in different quadrants and see whether it is total loss of vision or whether it is hemianopia. If it is hemianopia, what type? Homonymous or bitemporal. So these defects or type of defects will give you idea about the site of lesion. Other canals are the third, fourth and sixth, that is oculomotor, trochlear and abducent. They are basically associated with the movement of the eyeball. So when you check the eyeball, basically you can check all the three at the same time by making the patient move the eyeball in different directions. Abduction, adduction, upward movement or lateral movement, either in the center resting position or in adducted position or abducted position. So basically these three cranial nerves, they control the function of the extraocular muscles, and also the third nerve controls the pupillary reaction also to light and accommodation. So basically these nerves innervate different muscles, and they are active, most active in different position of the eyeball. For example, if you ask the patient to look outward, that is abduction. This is the role of the lateral rectus muscle, which is supplied by sixth or abducent cranial nerve. While the other functions like adduction is by the middle rectus, which is the third cranial nerve innervated muscles. While the superior oblique muscle is responsible for downward movement. It is innervated by the fourth cranial nerve or trochlear nerve. But you should know that oblique muscles are most or best active in the adducted position of the eyeball. So if you want to check the fourth nerve, you ask the patient to look inward and downward. Then you will be basically making the superior oblique to function. So if you want to check the fourth cranial nerve or superior oblique muscle, the eye should be in adducted position, and then ask the patient to look downward. while the recti are most active superior and inferior in the abducted position. In that case, you will be checking the third cranial nerve best. So basically, when you look for the movement of the eyeball in different directions, you are basically checking whether the movements are normal or not, they are full or not, and depending upon the abnormality, you can find out whether the lateral rectus or middle rectus or superior, inferior, oblique, etc. are abnormal, and you can conclude which particular cranial nerve is likely to be at fault. So basically, when you examine the eye, first from a distance you see the patient's eyeballs are looking normal or not, whether there is any ptosis or not, any squint is there or not, or whether there is abduction or adduction of the eyeball. And also you see the pupils are